Good afternoon to the distinguished speakers for today's public forum. My name is Xiao-Ik, and I'll be your moderator for the session today on living with a brain injury. Now, some of you are here today because you yourself have been affected by a brain injury. Perhaps you were or are a patient, or perhaps it was your family member or a loved one who's been through a brain injury. And I want to applaud all of you because whatever the situation, you've been through enormous challenges, and it's really amazing to have you here with us today. And of course, the purpose of this panel is to give all of you an opportunity to ask our panel, our expert panel, any questions that you have regarding brain injuries, whether it's about what to do when you're in the hospital, the recovery stage, what to do at home, especially if you're caregivers. So we'll be accepting questions throughout the forum. There won't be presentations or long lectures from our speakers. They are here to dedicate their time to answering all of your questions. So there's no specific Q&A time. At any point when you have a question, after I kick off the discussion, please raise your hand. We have Miss Tiba. She's sitting in front, but she'll be keeping an eye out for anyone who raises their hands. She'll pass the microphone to you and you can address your questions. We also have received some questions from the public prior to today, so I'll be raising some of those as well. Lastly, two quick housekeeping announcements. Please put your phones and devices on silent, of course. And at the end of the forum, and I see our doctors now checking their phones. And at the end of the forum later on, we request that you help us by filling out a feedback form. There's a QR code that you can scan at the registration counter outside, so you can stop by and do that. But before we kick off the full discussion, I just want to invite our consultant neurosurgeon here, Dr. Muruga Kumar, to provide us a brief welcome note and what to expect.
Good afternoon, ladies and gentlemen. And again, warm welcome and thank you for coming this afternoon for this inaugural get-together of, we have titled this as brain injury. So brain injury covers, so you might be patients, you might be loved ones, or with your relative or someone that you know, a friend who has had a brain injury. So brain injury is this whole enveloping topic that covers anybody who's had a head injury from trauma, a fall, an accident, or somebody who's had a stroke, and somebody has had an infection in the brain, and now there is some sequelae and there's some post like scarring in the brain, and you need to know how to deal with. So this is an inaugural session to get a feedback from what the community expects from us and how we can provide some sort of support. And if this is successful, we would like to have this as a regular session. And on top of it, is a thought that I've been thinking about for some time is if there is a good response from the public and you feel that you need a brain support group, that means some sort of a brain support group, whether it could be at a hospital level or a community level, working with the Subang Jaya community, because we have, the municipality here and the assembly people, whether we can call a brain support injury group, an NGO that can address some of these issues with participation from the hospital, participation from allied medical personnel, as well as patients and family. So that's, I think, the start of this this session. I'll pass on the mic.
Yes, and thank you so much, Dr. Muruga. I would like to introduce the rest of our expert panelists to all of you today. That was consultant neurosurgeon Dr. Muruga Kumar. Next to him is Dr. Mohana Vail, consultant rehabilitation medicine physician. And after that is Dr. Gurmit Singh, also consultant neurosurgeon. Dr. Raminda Kaur, a consultant psychiatrist, and Ms. Huang Ke Lin, clinical dietitian, all from SJMC here, and representing a multidisciplinary panel, which shows you how important that each of these roles play in the treatment, management, and diagnosis and recovery following a brain injury. I'm going to kick things off with some questions for our speakers today to set the stage. I think first of all, we need to understand what do we mean when we talk about a brain injury? What kinds of injuries are we most concerned about in terms of the as you said, Dr. Muruga, it could be trauma due to an accident, but there are other conditions that can lead to brain injury. So maybe you can provide that context, and then which parts of the head and brain are affected by these injuries. Dr. Muruga, and Dr. Grumit?
Head injury can be caused, like Kumar said just now, it can be caused by anything. You can have trauma, you can have infections, you can have a tumor. Post-tumor surgery also can give you. The thing here is the manifestation or the symptom or the outcome is nearly the same for all. There could be psychological issues after the surgery. You cannot move your hand, cannot move your leg. You get very depressed. After the accident, you probably you can't move your hand. So these are psychiatric manifestations. So any of the causes that I mentioned can cause this manifestation, these symptoms.
I think stroke as well is a big an upcoming. It's a very common problem as our population ages, and the family members and the friends are the ones who need to handle these patients later at home. So I think just to touch on it, because we have there is an acute phase and there is a long term. And most of us are only looking at the acute phase. That means the time the patient spends in the hospital with the initial injury, whether it is a stroke or a trauma. But there's a lot to do with the rehabilitation, and the dietary constraints, psychological issues that the patients might face 3 months, 6 months, a year down the line. These are the things that we want to address today.
Yes. I want to get the acute phase addressed first before we move into looking at longer term recovery, being at home, and all of that. Dr. Gurmit, what should patients and their caregivers expect in the acute days right after there is a brain injury? What does the physician do for their treatment and their care?
The initial stage is there's a lot of anxiety in the family. Just say your loved one just had an accident and now it's in ICU. Bad if it's operation. So there's a lot of anxiety in your mind. What will happen? What will happen? What will happen? Over the next couple of days, things will start to become more clearer. Hopefully, he's recovering. Then there's relief. Then he moves out from the ICU. At the ICU level, there's nothing much for you to do. You're only daily interacting with the physician. Then he comes into the ward. Now, this is where we neglect. The doctor also neglect. The patient's family also neglect. There's a lot of relief. The brother goes back to work. The sister goes back to Kelantan. The father starts to go back to his job. Then every evening you come to visit. So over the next 2-3 weeks, this happens. Next thing you know, the doctor is saying in 2 weeks you can go back home. But you have not learned how to take care. Don't know how to give a feed. Don't know how to give him a bath. Don't know the physio. Because once this acute then subacute phase finishes, you're sent back home. Do remember that the hospital is only for acute care treatment. We don't have chronic care treatment in this country. In other countries, we have started now. Like in the government side, we have a hospital charas, something along that way. Here, we can lodge you in, but then it's financially, it's costly. So those of us who cannot afford us, I include myself in this, those of us who have cannot afford this, then you must, at this subacute phase when he comes out from the ICU, learn how to take care, give a bath, physio, feed. Many people omit or forget to do this. Then the moment the doctor says, okay, you can go back home, then you get freaked out. Then it really, you take back home and the level of care drops there significantly. This is where bed sores start to develop, pneumonia starts to develop. You did not feed the patient properly. The Riles tube, you feed very fast, or you didn't prop the patient up. Patient aspirates, then comes back to the hospital. These are the things you need.
Okay. I want to start to bring in some of the questions we had received from the public. But again, I'd just like to remind you all, please raise your hands anytime you have a question yourself. Dr. Mohana, I think this one I'd like you to give us an overview. A lot of questions came in touching on recovery, using that word. What are the chances of recovering from a brain injury? And I want to expand on that to ask you to also tell us, what does recovery mean? It is not just about getting discharged from the hospital. What does it look like in the context of each individual's life?
Okay, when you talk about brain injury, okay, due to variable cause, okay, as we all know, brain controls everything in our body. Okay, so our cognitive function, okay, our cognitive function means the way we think, the way we pay attention, okay, our executive function, the way we make decision and all that, okay, and memory and so on. And the other part is our physical function, okay, the way we move our limbs, okay, limbs, and also behavioral, how do we behave after loss of function. Okay, so sometimes we'll get easily irritated, agitated, okay, impatient, and so on. And then we have emotional, okay, we have they get sad, depressed, and so on. Okay, and then sometimes we may have other psychological issues going on. Okay, so all these causes loss of function. So any of these affected, okay, depending on that extension, how extensive is the injury, then we have to deal with this. So recovery basically depends on how bad is that injury. Okay, so let's say in a brain injury, okay, things are a bit different. So most of the time it's very diffuse. Okay, so it can be right from very unconscious state, okay, from mild traumatic brain injury where they may just lose a bit of consciousness and then recover, and then they may have a bit of a behavioral issue and all that. So in this case, recovery is depending on that what is the loss function at that time. Sometimes if it is, let's say, if a simple case of stroke, okay, they may have weakness on one side, okay, paralysis on one side. So the recovery can be good. Okay, so when we talk about recovery, we talk about restoring that loss function, or adapting, or compensating for the loss function in different ways. Okay, so that is recovery lah. So and then recovery also depending on the loss, like cognitive recovery, we have to train them differently so that they're able to live independently. Okay, that is recovery. It's very extensive lah, so it's very difficult for me to pinpoint how is going to be the outcome.
But if a caregiver or a patient basically just has one concern in their mind, can I get back to work? What would, how would you help, address that?
Okay, again, so it's very general question. Okay, so it depends on what is the patient's disability at that time. Okay, if the patient has got only physical disability, okay, his executive thinking, his cognitive function is okay, he's able to have good memory, able to sequence his activities, okay, able to do calculation, able to do writing, reading, everything in a normal way, then they can go back to work. Maybe we can train them to go on the wheelchair, or we can use walking aid and so on lah. So that is recovery. So it depends on what is that loss function.
I think to summarize this is brain injury is serious. I mean, it's not comparable to whether you have a fracture of a bone, your wrist or your leg. There are time frames, very clear time frames, because the bone will heal within 6 weeks to 3 months. And if you fix it, we know this person is going to get back to what they're going to do. But the brain is a very complex organ. It is your main organ. So, and when you talk about brain injuries, you're talking about traumatic brain injuries where an accident or a stroke or an infection, and post brain surgery, post tumor. Now, the thing that I think the take-home message that is very important for a lot of people from this question that has just been addressed is that you have this anxiety. When can I get back to my normal life? It's all lost. is all hope lost. Now, the first thing I always tell my patients in the clinic is that the brain takes time to recover. Give it 6 months, give it 1 year. We have seen huge number of patients that look completely hopeless in the first week, the second week, the third week. But 3 months, 6 months down the line, this patient has learned to cope with some of the disabilities, has improved significantly to get back to some normalcy of life. And this is what we need to get the message across. Don't expect quick recovery. It takes time. It can take 6 months to 1 year, but most patients do recover a certain amount. So do not make your judgment on the first week or the second week.
Recovery is directly proportionate to the amount of time, energy that you invest. So don't take the patient back home and then say, I remember doctor telling me, give it a bit of time, it will improve. It's not going to happen. If you do not invest time, physio, rehab, massage, mental stability, it's not going to work. You can bring the best physiotherapist, you can make a gym at home, but if he's depressed, he's not going to do anything. So it's multidisciplinary.
And speaking of depression, my next question is for Dr. Raminda. We had a question from a member of the public. Is emotional trauma related to a brain injury? And perhaps you can also expand what are the signs that somebody is actually experiencing what you might call emotional trauma?
Thank you for the question. Looking for my clinical referrals to the wards when patients are admitted, the first symptoms that appear is patient is restless, patient is irritable, patient is agitated, and then the patient has to be tied down. And that is so traumatic for the family, right? And the family doesn't know what is happening. So that itself tells you that, wow, what is happening here? And you're right by saying that there's so much of sadness, confusion, disorientation with the not only with the patient but also with the family that is waiting outside, peeping through the door what is happening to our loved ones. So definitely there is a lot of emotional trauma going on here. Anxiety is number one, depression is number two. Sometimes some patients even have suicidal ideation, and that can be very traumatic for the loved ones, and what more for the patient himself, right? So never underestimate the emotional and behavioral issues that patients can exhibit upon sustaining a brain injury, right? And I'm very glad that the neurosurgeons here are actually able to pick up some of these symptoms. And when they tell me that, look, Raminda, go ahead, you can do your best. You don't have to worry that the organic part of the brain injury is going to affect your management or treatment of the patients. So I'm glad that this issue was brought up, and this issue has to be addressed while the patient is still in the ward. All right. And not only that, the family has also to be educated on why this is happening to our loved ones. Right. So there's a lot of education involved here. And this is part and parcel of brain injury.
Dr. Raminda, is there a perception that if we give it time, to borrow Dr. Muruga's phrase, that these emotional issues will resolve themselves? And is that perhaps the wrong thinking?
I think it's more of a myth rather than a fact. These issues cannot resolve without any psychological intervention or psychiatric intervention. All right. Treatment is needed if the patients are very, very unmanageable in the ward. And this treatment is short term, it's not long term. Once their behavior is settled, we actually taper off the medication that is given. But more than that, if these complaints are not addressed, it's not going to resolve by itself. This is from my own clinical perspective, all right? Because you need to educate our patients, and not only our patients but also the family and the caregivers, right? Why he or she is behaving in that way, and I don't recognize him anymore now. So there are also personality changes going on here, and the frontal lobe is actually home to our personality. And I think if the surgeons would agree with me, it's the frontal lobe that is causing most of these emotional as well as behavioral symptoms when there's a brain injury patient.
I would like to bring Lynn into the conversation now as the dietitian in the room. And I think the return to normal functions, as gradual as they may be, eating will be such a big part of that. Perhaps you could explain to us how the, I guess, physical and physiological functions that are related to eating, right? The basic act of chewing, swallowing, perhaps, and eventually feeding oneself. How would that be affected during a brain injury?
Okay, so there are various challenges, feeding challenges following brain injury. So during the acute phase, I think swallowing difficulty could be one of it. It is pretty common for patients who couldn't eat. It is not safe for them to eat orally because they are unconscious. That's where we will start with tube feedings. Yeah. But for patients who could actually slowly progress from there with the rehabilitation, with the speech therapies and all, they might be able to slowly start to eat a little. For example, for post-stroke patient, but we need to expect that it takes time as well. So we do not pull out the tube immediately. We will make sure the patient is eating perhaps at least 50% of the requirement. Then only then we will decide to educate them on how to progress the diet from a tube feeding to eating safely through the mouth. So unfortunately, there is no magic food to reverse the condition of brain injury, but there are also evidences saying that perhaps a Mediterranean diet, which is very rich in whole foods with omega-3 fruits, vegetables, which is high in antioxidants, to help with the recovery of the brain injury. Yeah, and also I would like to address, actually there are also patients who experience loss of the senses of smell and taste, which can be a long-term issue for them, which they will just need to adapt to it. So for that, I think it could cause a lot of issues apart from not eating adequately. I think my personal experience when I got contacted with COVID, I lost the sense of taste, and I'm pregnant at that time. So I know eating is important for my baby, but I couldn't do so because I can't taste my food, you see. So of course, there are ways to help. Yeah, if you are able to make sure the meals are served in a more attractive manner, we try to include different textures or even the temperature of the food, combining cold foods and warm foods, or even eating as a family. I think all this help, I think that are some of the issues that patients might face, during injury.
How long does tube feeding actually continue for? Would patients still require it, perhaps when they've been discharged and go home, for instance?
Sometimes it could be just a temporary one. Before they discharge, the tube is removed. Yeah, but for a certain case, it might be long term. So if the doctor is already know that this could be for a long term, they would actually change the route of feeding from nasogastric to PEG feeding, to help to reduce some of the challenges during feeding. It could be pneumonia, So there is no clear say of the duration. It depends on the severity of the injury as well.
And we had a question about whether homemade blended diets could be prepared for tube feeding.
So it is not commonly practiced in hospitals in Klang Valley. So during those days, I think when the standard formula, what we call as the milk powder, which you can see also at the aisle, when we don't have much access to it, I think that blenderized tube feeding (BTF) is very common to be practiced. Yeah. So whether is it yes or no to continue that with the availability of this, there are actually certain concern. I would say yes if the patient is for long-term tube feeding, and there is some feeding intolerances. Even though they tried all the formulas, it causes a lot of unpleasant experience, like bloatedness. They get reflux. Yeah, so there is where perhaps BTF is one of the solution. Yeah, or if the family or of course the patient need to be really committed to it, whereby I think we are going back to more real food now, because all this like milk powder, it is commercially made. Yeah, so if you think you are able to work closely with dietitians to really plan something nutritious enough for yourself, then maybe yes, BTF is good for you. And also for psychosocial support, yeah, there are caregivers who are really wanted to prepare something for the patient, yeah, or the patient themselves, they would feel more they will have more joy because they have limited control over the other treatments, the medications, the treatment. They don't have control over it. So if they have control over what are the food and drinks to be put on to them, then perhaps BTF is one of the thing that we are looking into it. But of course you have to be careful. The feeding route, it could be the more advisable one would be PEG. The feeding tube should be, the size should be at least 14 French size, and of course work closely with us to know more about the recipes, because certain ingredients, for example bananas, it actually thicken the mixture, so it can cause clogging of the tube, which can cause other complications then. Yeah, so there are precautions to be taken if BTF is to be used at all.
Why Ryle's tube, which is known as tube feeding, over PEG? So advantage, disadvantages. In in a Ryle's tube, it goes into the nose and then goes down into the stomach. It sits at the stomach, within the stomach. So if you feed too much or too fast, it regurgitates, it comes out. So if you are unconscious and somehow your caregiver has not propped you up at 45 and put you flat, so it comes out, goes into the windpipe. From the food pipe, goes into the windpipe, and then you get aspiration pneumonia. So that can be fatal. Now, on top of that, the with the peg, it sits in the stomach also, but there are less complications compared to the Ryle's tube. Number one, when you put the tube into the nose, you anchor it to the nose, you plaster it here. If you watch very carefully, some of your cousins, some of your family members, loved ones who have got stroke, they have black marks. Those of us from General Hospital will see, because the tube is anchored here very tightly, so you get black marks around the ala. This is known as the ala. So that cosmetically, number one. Number two, as the tube goes in through here, it goes at the air sinus, passes by the air sinus, and the tube blocks the opening of the sinus here, because there's a lot of mucus producer. Naturally, it comes out by itself. But when the tube is sitting next to the opening, it blocks it. So what happens is the mucus, the secretion retains within here. And as it is, you are bed bound, your immunity is low, your nutrition not that great, this gets infected. So then you have sinusitis on top of all your other problems. You have sinusitis. Normally, when you're walking around like this, it comes out. There is a ciliary action. That means there's some natural action where the body itself takes out, cleans out the mucus from here. But because of that condition you are ill, it's not brought out. It's left in there and gets infected.
Post-stroke, post-severe head injury, when the patient can tolerate orally well, can eat, and we discharge these patients going home. One of the common mistakes is feeding too fast and too much in a feed. So these patients have just had a brain injury. Their swallowing reflexes, their ability to control is a bit disturbed. So you should give small feeds and more regular. So don't rush the patient. I mean, the caregiver wants to give the most, and because you want to feed them as much as possible, sometimes overfeeding has become a problem. Too fast, not the quantity, but too fast.
actually, when you talk about NG feeding, okay, so the oral sensation does not count. Okay, so whatever food blended or anything, they won't be able to have that taste. So it still goes directly to the stomach. And to add, okay, our NG feeding, so when you discharge from the hospital, like Dr. Kumar said, they would have decided on the amount, okay, the volume of that milk that you're going to give, whether it is safe, whether it is going to cause any bloating or other unpleasant sensations and so on. And the milk that has been prescribed by the dietitian at that time is quite complete. Okay, so to take all that important nutrients and micronutrients, everything, the volume, that the calories that are needed is already decided. Okay, so you giving that blended, I mean, diet, I feel it's not going to have any extra benefit, or maybe it may be not be supplementing enough. Okay, so that's the reason lah. And how long do you keep the tube, depending on time to time assessment of the swallowing function. If the patient is able to swallow safe without having risk of aspiration, it's okay, we can off the tube. So before we decide, it's a safe way is to do some testing, important testing. We do what we call a flexible endoscopic evaluation of swallowing, okay, done by the ENT doctors and also the speech therapists. So there they feed the patient real time, and then they check that our valve in that for swallowing. So there, then we decide, is there aspiration? If there's no aspiration, then it's safe. We can allow them to do oral feeding. If it is not safe, then we have to continue to give tube feeding. And then if the tube feeding, you feel it's taking very long, okay, the tube is causing some what do you call image problem to the patient, okay, causing some excoriation at the nose and all that, then we can think about PEG tube, percutaneous enterogastroscopy tube, where it's the same, but this tube is a bit the lumen is a bit wider, bigger. So here, I mean, when the lumen is wider, the risk of like that food getting clogged and all that is a bit lesser lah. It is still there, but a bit lesser. So there, sometimes in chronic patients, sometimes people do give some blended diet. Okay, so which is okay, but we must supplement also with milk lah. Okay, because milk provide complete calorie. Okay, so that's the my point of view lah.
Thank you so much for that. I mean, we had almost everybody weighing in on this so-called simple thing, right? The ability to feed the patient. And I want to use that to continue talking about rehab, Dr. Mohana. Couple of questions that we had received also, I just want to read out. Suami saya baru dibedah sebab otak dia berdarah. Has just gone through surgery following bleeding in the brain. Kami perlukan bimbingan penjagaan. Right? And another question was how to take care of a patient during rehab. What are the stages of rehabilitation and what's the duration? So if you could walk us through, Dr. Mohana, I know again it's a big question, but what may be the kinds of different therapies or support that patients and their caregivers should expect?
Okay, so when you talk about, I mean, it's a different brain injury is different. I mean, head injury is different. When you call about traumatic head injury, it's from an accident or fall or gunshots, things like that lah. Okay, so that is head trauma. When you talk about bleeding, like what that the question says, berdarah, is it? Okay, that is intracranial bleeding lah. So that is called, sometimes we call it as hemorrhagic stroke. Okay, it's a kind of stroke, but it's a bleeding type. Okay, so bleeding type of stroke, it's sometimes can be quite focal, or sometimes can be very extensive bleeding. Okay, where our neurosurgeons need to step in. Okay, so if there is no neurosurgical intervention, okay, then becomes we have to, it's quite complex lah. We have to assess again how is the consciousness state, how is that how the patient responds, what are the disabilities there, is there any like hemiplegia or one-sided weakness, is there a swallowing difficulty, is there any uh, like pain and others that we see. Okay, so first we have to like assess, and then we have to go do rehab. First thing is we must mobilize them early. Okay, so we have to mobilize them, we have to like make sure the joints are still able to move. If we don't move the joint, there's no limb physio, then the joints may become stiff and at one point may become contracted. Okay, and then we must always do the initial like movement mobilization to prevent things like pressure sores and so on. Okay, and then to prevent that pneumonia, that that orthostatic pneumonias and so on. Okay, so this is that for the bleeding. And then we have to always, if the bleeding is so severe, the patient is not waking up, the consciousness is reduced, then we have to train the caregiver. Okay, caregiver should be trained like how to feed them properly, how to turn them, how to take their hygiene, to do the hygiene care for them. They need to wear diapers, how to put. I mean, this is something new, you know. So baby putting adult is easy. When you talk about adult putting diapers, it's a totally different experience. Nobody expects. Nobody is. It's now we have to do the teaching for you all, to the family, to do it. Okay, and then how to clean the body, clean the perineum, how to take care of that motion part. Okay, how to do that care for the urinary excretions, and this thing needs training. So in the hospital, in the early phase, okay, if we decide the patient is for the caregiving, we will call in that family. Okay, decide who's the caregiver. Okay, or if the family is that some of them have difficulty to spend time, okay, then we will suggest for them to get a paid caregivers. Okay, so that's how it works lah. So the caregiver training, so we will hospital will train them to do all that things that needed to sustain the care. Okay, and then in brain injury, head injury is different. Okay, so when you talk about severe head injury, so we have to like classify them. Okay, how is it early comatose stage, or is it vegetative state, or is it a minimally conscious state, or is it a like agitative state, and so on. Okay, so depending on each stage, okay, the rehab is a bit different. Okay, the first two stage like comatose or vegetative, it's quite simple. Okay, we just make sure that there's no complications that of prolonged bed I mean lying down on the bed. Okay, so there's a lot of complication, so we'll try to prevent that, and also at the same time do some stimulations and all the stimulatory exercise. So this is done by a teamwork. Okay, so we have physiotherapies, we have occupational therapies, we have speech therapies to do everything, and of course the nurses. Okay, so it's a teamwork that you need to do it lah.
Question here that perhaps Dr. Raminda, you'd like to try to take it. After a traumatic brain injury or damage from a stroke, is there a way to ensure complete recovery from symptoms related to aphasia, which I think is losing language, or memory loss?
I think aphasia is loss of ability to speak. So, and this is a brain injury. So the area that contributes to your speech function might have been injured in the stroke or in the trauma, and some of this is recoverable. So it's not a final sentence that this person is not going to speak in the future. And we have speech therapists for this who can guide these patients as they slowly recover in the path. The brain takes time to recover. So I think it's very important to understand that there is an acute phase, and in an acute phase, the brain is in a shock stage. So whatever you do to the brain at this point, it's not ready yet. It's going to take its time. So you got to give it its time. And usually it might take 2 weeks to 3 weeks to a month when the brain has come out of this acute phase where the swelling has settled, the blood clot has disappeared, and now the brain is ready to start working again. and there is plasticity. Even if that part of the brain is damaged that controls your speech, there might be another part that might help in recovery of some of the speech. And that's where the speech therapist comes in and the rehabilitation comes in. Gurumit, you want to continue?
The damage depends on the amount of area damaged. The aphasia or the permanency, is it going to be permanent or not, depends on the area of damage. So if tiny area is damaged, then the possibility of you recovering your speech is much higher. If large area is damaged, then the probability drops. But there is plasticity. What Kumar mentioned, there's plasticity. We want to try to force the neighbor to take over the job of these nerves. So that always we try to work towards that. Hence, that's why we want our physio, OT, speech therapist to come in.
What about memory loss? That was the other part of the question.
That's cognitive executive function. Here again, we get our occupational therapist to come in, our physiotherapist to come in, to stimulate you, to push you, to encourage you. Two things can happen. Either you sit in your room, in your room, and not come out and mope and depressed, you are not going to recover. The other thing is come out, engage actively. Of course, you're depressed. This is where the family members come in. This journey is not to be taken alone. Family member, patient, medical team, everybody is on a long journey. It's not a short one. Let me assure you, it's not a short one. It's going to be a long one.
Yeah. I would like to add in. So aphasia, okay, and also this memory thing, the main problem that they cause is communication. Okay, so where they cannot communicate with any that environment or the people around them. So when they will recover, it depends on the brain plasticity. Okay, brain plasticity is something like our nerve cell does not regenerate, does not recover. Once dead, they are dead. Okay, so what happens is that new connections will take place from different functional areas. So how this connection does not come itself also. So we have to train them, do repetitive activities so that the new connection do that function. Okay, and when you talk about aphasia, can be sometimes expressive aphasia or receptive aphasia. Expressive aphasia is when they understand what we are talking, okay, but they not able to express what they want to say. Okay, receptive aphasia is when they cannot understand what is going on. Okay, but sometimes they can talk something, but it can be a bit of unrelated or something. Okay, so memory wise, okay, also same. Memory goes back to like short-term memory or working memory or long-term memory. Okay, so most of the time memory areas are quite extensive in the brain also. So there is limbic system, there is posterior brain and posterior lobes and all that. So they have all the lobes has got some area of memory. Depending on what memory is lost, sometimes we need to do recalling. Okay, we have to train them. That's where our occupational therapy, speech therapies, neuropsychiatrists. Okay, I forgot to mention all this aphasia and also that memory thing. So we have neuropsychiatrists, neuropsychologists. So where they try to retrain their brain activity. Okay, so it's when he's going to recover, it's like Dr. Gurmeet says, it's long term. Okay, based on periodical assessments. Okay, and how much you rehab, how much rehab we put in.
Yeah.
Okay,
We have a question from the gentleman in front here.
Coming to Dr. Kumar, and just now you suggested that to have an NGO or to have a support group, I think it's an awesome idea. Because brain injury can happen to anyone at any point of time. You can go off in the morning going to work and you can end up having a brain injury and the whole family members won't know how to cope with it. And what Dr. Gurmeet explained just now, that from the ICU and once you come out, the next phase, the family members won't know how to cope. That's very, very true. Now, my question is this: I understand that building a person's ability to walk and all takes a lot of energy, time, and effort. And my question is this: a person who has a fall and has had a brain injury, um, the confidence level of the person drops significantly, meaning to say that the person will be so afraid to walk. Okay, and sometimes the family members don't understand this, and the person is already on the wheelchair, and moving from the wheelchair to the walking phase takes a lot of effort from the family members and also the person. How the family member can actually coach or to build up confidence in the person who experienced fall?
It's a very relevant question, and I'm glad that you brought it up, because one of my own family members has been wheelchair bound ever since she had the fall. So as I said, that psychiatric input or psychological input is very important from day one, when the doctor, the primary doctor managing the patient, elicits such symptoms. Either the ward staff is telling them that they realize that this is something that need to be addressed. So from the very beginning, as a doctor, I need to talk to the patient to understand, where is this coming from? Where is the fear of walking again, in spite of having the physiotherapist on board, right? Not only that, not only talking to the patient, but also to the family members, so that we get the full history of why he has this fear, in spite of doctors telling him that, look, you're good, you're all right, you can step on the floor and start walking, because the physiotherapist would have come in, all the relevant doctors would have come. But why is he still having the fear? So this actually, you need to actually get cognitive behavior therapy ongoing to understand, so that we can think about how is he reacting to the fear, how his thinking abilities, his own assumptions that if he walks, he's going to fall again. So it is a process. It can be started from day one. That is a psychological intervention. But if, as a doctor, if I feel that some amount of psychiatric medication can help, because he would be already depressed. Not only depressed, he will be already also having certain amount of anxiety on board. Then sleeping problems, right? So, and also don't forget that he's in an environment that it's very different to him now, right? Simple things like the temperature, it's very cold. He can't take the coldness in the hospital, especially when he's in CCU, HDU, ICU, and then he will already have some problems there already. And we think that it's because of patients' behavior problems or what. So it starts from day one of admission. But when it comes to a normal ward, things are totally very, very different. Yeah. So what I'm trying to say is that it starts from day one. And we start slowly, but when he's in a normal ward, that's the time when you have to really, really intervene. So we try to correct not only his sleep, but also some amount of his anxiety and depression. Low dose of medication, so that he's able to pull through. He needs to have some amount of clarity, because when you do counseling or you do any kind of psychological help, he has to be clear up here, right? He can't have a brain fog. So if there's no clarity, he won't be able to understand what we are trying to say to him. So in short, yes, psychological treatment is available, but medication also plays a role, but short term only. All right. So that's my short answer to you.
I think this is a very good question and a very pertinent question, because I've been a neurosurgeon now for nearly 25, 26 years, and starting in HKL time, we've seen a lot of head injuries in the late 80s and early 90s. We didn't bring in the psychologists and the neuropsychologists, psychiatrists into the picture. This has been overlooked. As neurosurgeons, we just look whether the guy can talk, can walk, can go home. We never looked at the background of the anxiety, the depression, and these issues that affect the patient as well as the family around them. And unfortunately, we are still a developing country. We want to move forward. And this is something very common in the West where you have neuropsychological support for these patients. But in this country, it is in infancy, it's still starting. But we've addressed this. So in private hospitals, at least, we can get the psychiatrists and the neuropsychologists involved early to advise these patients. One key thing that I think society has failed to understand, a patient who's had a stroke, who has had a head injury or a brain injury, we want to get him back to being a useful person again. Now, these patients, if they have got fear, anxiety, they end up not getting back into the mainstream of society, not being able to go back to their jobs or to participate with society. And this is where neuropsychology and the psychiatrists play an important role. And I hope the take home message is that this is short term. As what Raminder is saying, this is not addictive. We are not going to give you medication for the rest of your life to become dependent on some anti-anxiety or anti-psychiatric medication. This is a short-term solution because your brain will eventually recover and then you won't become dependent.
Having said all this, I will also keep a very close eye on my diet, because if I'm having muscle weakness, I'm in hospital for the last 3-4 weeks, and then you expect me to start walking within the next 2-3 weeks, it's not going to happen. I have had sarcopenia, meaning I've lost muscle mass there. So also focus on rehab, on physio, on diet also. So when you're trying to wake up, your legs have got no power, and people will be telling you, this guy is malingering. So that is also keep an eye out on the diet and the physio also.
Any other questions from the floor? Yes, we have one at the back.
Hello, good afternoon, everyone. Thank you, SJMC. It's very, we are very lucky today to have all these panel of esteemed professionals, specialists here. So I've got this actually a long list of questions, but you talk about acute and chronic, okay? So I got a very unique situation. My sister-in-law got a stroke. Feel nausea, went to the toilet, unconscious. Then, as usual, call hospital. Then ambulance came. The 999 ambulance came, and the next thing is my brother-in-law straight away sent her to a public hospital. So it was Saturday today, a couple of weeks ago. Then next thing you know, scan, and then can't do much. Say wait for Monday for specialists to really see what's the actual diagnosis, right? So I just want to get some opinion here. In a similar situation, my brother-in-law just realized, hey, we are professional. We are well covered in terms of insurance. I would like to send my wife to the nearest specialist hospital. Would that make a difference in terms of time of recovery diagnosis? Because in her case, the doctor comes in the following Monday and say, okay. Then a couple of days later, she woke up. Then 2 days later, she got difficult breathing. Then next thing they know is like the bleeding got worse. Then went for emergency surgery just to release the pressure. She's supposed to wake up like 2 days later. But unfortunately, after 1 week, she didn't wake up. But then, as usual, all of us loved one, we start praying from every angle, every religious tree, every belief, right? But thank God she woke up. She woke up, then she was in ICU again, all right? Then somehow or other, she moved on from ICU to the normal ward. Then next thing you know is like, because of public hospital, then moved to so-called rehab hospital nearby. Then next thing we know is she's been discharged. But the thing is, my brother-in-law may not be as clear as I am, because I'm the risk management professional, but not on the brain surgery injury. For us, straight away, diagnosis, we got to be very clear what's the situation, get the panel of specialists, whether it's software or hardware. Then you got to put on the table, diagnose and get a proper treatment regime. At least we know each and every day. Get back to this specialist to see, hey, what should we do? We try this 1 week, 2 weeks. If not, what should we do? But in
So
my
your
case,
question is the duration, the
yeah,
number of
should-
days.
should we go to a private hospital or public hospital now? This is acute. I haven't thought about the chronic. Okay, it's a long story. Sorry.
Depends on the.
I think the service, whatever you must say lah. Before that, time is brain. That formula. Time is brain. Spend more time, less brain left. Faster, more brain safe. That we all agree. Same thing in heart also. There you go. One more. Let me. I'll just finish this. The other thing is, I think if you say which one do you come to, the private hospitals have got less patients. The probably they can attend to you faster. So that's the difference lah. In the public, there could be 2 strokes could have come at the same time. The on-call guy is running around trying to handle it lah. Here, private hospitals, probably one individual is got more chance to focus on you lah. That way.
We were thinking about to transfer hospital to private. The first private hospital we call actually is SJMC, emergency room. They rejected it, unfortunately. So from there she was hanging in the government hospital.
So I think this is a difficult situation. Strokes are common. They're getting even more common these days as our population changes and our dietary habits change. So we are becoming more prone to strokes in this country. It's unfortunate what happened to your loved one, your relative. But there are solutions to this. And I think in the future, as what Gurmit has said, is that we are looking at, hopefully we can move forward as a community, as hospitals, that we have a brain attack kind of like a heart attack, a brain attack kind of a protocol. Where now it is very common if you have a heart attack, myocardial infarct, that you immediately, the whole process starts off. But in this country, we are having shortage of neurologists and the relevant specialists to have a team to address this. And this is something that we are bringing up to the hospitals, that we need to give the priority to a stroke as equivalent to a heart attack. And so that somebody who has had a stroke has got the same 30-minute process of fast tracking from a CT scan to a diagnosis. Anything can be done, cannot be done. Getting the surgeons involved, the neurologists involved, the ICU specialists involved from the very beginning, not waiting for 48 hours or 24 hours. So this is something in the process that's being worked. Unfortunately, none of the hospitals in the private sector as well have developed this team approach, something that we are pushing for.
Perhaps SJMC can take the lead in that.
The one other thing that I wanted to say just now, going back to your question and the whole audience here, when you have a stroke or a brain injury, whether it's the patient or the relatives around the patient, please ask for help. Do not be scared to ask. We have to move away from that culture that we cannot ask for help. Today, I saw 2 patients with a stroke in my clinic. I mean, these are 3 months, 4 months. And clearly, one of the patients said, he is a high-flying corporate guy, an IT guy. And he says, whenever I think, I get anxiety and I get headaches. This is 4 months post-stroke. And he says, I'm worried when I get these headaches, am I going to get another bleed? Obviously, it is an anxiety attack. So I told him, when you see your rehab specialist, tell him you need some medication. Ask for the help. It is we've moved from this culture that we know now that you need help. And sometimes the doctors are too busy or they are not aware that you need the help unless the patient comes forward, we will not be able to help.
Trust me, guys, it is treatable and it only needs short-term medication. They are not habit forming. They are not causing any dependence. All the facts that we have with the lay public is, oh, it's going to cause me dependence. So and so has been on this medication for the last 10 years. You are telling me I need only for short term? Wake up. And if you see a classical case of anxiety, trust me, guys, it is so mind-boggling. Without treatment, short-term treatment, it can never fade away, go away. All right? Because if you experience an anxiety attack, you will know. You might say, the normal thing is, it's up here. But it's not up here. It's not supratentorial. There is a psychological component to it. And if you really take the history, you will know. Most of these patients with anxiety have triggers. Yeah, we need to get to the root of the problem. And that takes a little bit of time. Sometimes on the first sitting, you will not know. Subsequent sittings, you will know. And all these medications are tapered off. Maximum 6 weeks, 8 weeks, you can be off the medication. I just hope that if any of your relatives or the caregivers here or you yourself here have anxiety, please get help. All right? Don't shy away.
Thank you, Dr. Raminda. I want to bring
Can,
Lynn.
can I add a bit?
Just very
Okay,
quickly.
sorry. Okay, back to your question, sir. So, stroke, the time, like what Dr. Gurmeet said, time is brain. Okay, the longer you wait, the more hypoxia will be going on, the more brain cell will die. So, we have something called for stroke patient dot to scan time and then dot to needle time, meaning that the earlier you come to the hospital, get the scan done, if there is causing any, we want to know whether it's a bleeding type of stroke or is a infarct type of stroke. Okay, so if it is an infarct type of stroke, after some assessment, okay, the neurologist may do some procedure called thrombolysis. Okay, so this thing has to be done within 4 hours from the onset of stroke. Okay, so if it is beyond 4 hours, there's not much of benefit. Okay, and then if it is a clot, if there is there's another procedure called recannulation therapy, where they put in, the radiologist, trained radiologist will put in a catheter, go to your brain, the catheter goes inside the brain and retrieve the clot, okay, to revascularize. So this has to be done within certain hours also. Okay, so this can be done. So let's say if it is a bleeding type, okay, so our neurosurgeons will step in and go in and assess whether they need decompression or not. Okay, so they need brain surgery. I'm not sure what is your case, okay, whether it is a bleeding type or it's an infarct type. Sometimes infarct also after a few hours or after a few days can turn into hemorrhage, okay, bleeding again. Okay, we call it hemorrhagic transformation. So that one also sometimes the neurosurgeons need to step in to decompress. Okay. So having said so, I think your case, I don't know what really happened, why the ED rejected. Okay. Is it after a few days or?
Still within 24 hours because we want
okay. Probably we can approach one of ours to find out what really happened. Okay. So if they need rehab, of course, we are looking at SJMC. We have very complete services for rehab now. So right from any intervention, we are able to provide. Okay. And then the other thing is when we talk about that which hospital to go, of course, any condition, we have to go to the nearest hospital. Okay. So if you talk about that, which hospital has got the facility, so you have to explore. Okay, so which hospital has got a neurologist to do the thrombolysis, which hospital has got immediate neurosurgeon facility, or which hospital has got that radiologist who does that recannulation and all that. So it is this thing. So here in SJMC, everything is kind of complete lah. Okay, so
Thank you, Dr.
Okay.
Mohana. I want to bring Lynn into the conversation as well. A question from the public was, nobody wants a brain injury, but life happens. That's true, isn't it, sir? As you mentioned, are there neuroprotective factors that are within our control that could sort of boost our resilience if something like that does happen? And I wonder if diet might be something that comes into these neuroprotective factors.
All right. Like what I mentioned earlier, there is no magic food for that, but there are actually evidences showing that omega-3, it is part of the essential fatty acids which our body doesn't produce on its own. We need to consume by foods that which is rich in healthy fats. Yeah, healthy fats. So including fatty fish. So I'm not referring to only salmon. Actually, ikan tenggiri, our local fish products, do contain good sources of omega-3. Yeah, I'm also not referring to the omega-3 supplements only. We could actually get it from nuts, from seeds, of course, in moderation, because we don't want people to munch excessively on it, causing extra calories, being overweight, and increase the risk of stroke, you see. And of course, we could also get it from fruits. For example, avocado contains good sources of omega-3. Yeah. In terms of oils, if you are cooking your own meals at home, so it would be good to get different types of oils for a different cooking method. If you are drizzling just on your salad, so it would be good to keep some extra virgin olive oil. If you are doing for stir frying, then we are looking into canola oil, sunflower oil. So, but all this requires commitment, yeah, all right, and also cognitive behavioral. I mean, we do know all this information, but are we able to do it because of busyness?
Commitment and effort. Those are the words that are coming through today as well. There's
And also one
question.
more thing, alcohol consumption. I think drug or medication that is not prescribed by doctor or substance misuse, I think that is one of.
There's a question at the back. Yes, please.
Hi. Thank you, doctor, for the sharing earlier. So my question is, normally the obvious signs of stroke is sudden numbness of the body part, correct? So what are the subtle signs of stroke that we can spot on early?
If you're looking at it all depends on which area has been deprived of oxygen or which area has been damaged. So that will manifest. So if that area controlling hands is damaged, you will have weakness in coordination. You cannot. Commonly, what I hear is you're standing, you suddenly lose consciousness. You cannot move your hand, cannot move your leg, or you're talking and then suddenly you're starting to slur your speech, or you're drinking and then the fluid just comes out like that, or you cannot swallow, you're choking. Weakness, commonly numbness, suddenly my hands I couldn't feel. That's some of the things. Headache. Now, if it happens because of a burst vessel or because of a wet stroke, a bleeding stroke, then severe headache is one of the symptoms also.
Yeah, so if the symptom is just for a few seconds and then you go back to normal, and then suddenly maybe after a few hours and then you come back again, just like weakness for a few seconds and then come back.
So this is what we call, I think, this is what you're describing is transient ischemic attacks. This is condition is like a mini stroke. You're getting mini stroke. This embolic phenomena. That means the vessel is being blocked for a short while, opens up, blocks, and opens up. So this is also a feature premonitory of a stroke. You have to come into the hospital. If it's a recurrent symptom that you're getting every few hours or every few days, sometimes 1 or 2 days, then it is an indication of an impending stroke. So please, if you think that there's something that is persistent, a numbness that is persistent, a weakness that is persistent, it's coming over and over again, definitely come into the emergency room at any hospital and tell them you think that you're having a stroke. The most important thing is tell the doctor, tell the nurse, I think I'm having a stroke. We've had so many patients who come in, and sometimes my own good friends who come in and say, I'm thinking I'm having a stroke. So we end up doing an MRI, a CT scan, and thank God it's not a stroke. But when you tell a doctor that you think you're having a stroke, we take it seriously.
There is a screening. Okay, so when you want to suspect stroke, okay, so we call it fast screening, FAST. Okay, so you look at the face. If the face is asymmetry, one side is drooping, okay, it doesn't look symmetrical, okay, that is a warning sign for stroke. Okay, and then you look at raise your arm. If your arm is weak, okay, you cannot lift up your arm, so that is also one side you're risking stroke. Okay, and then you look at that your speech. Okay, your speech may be slurring, so it's not clear anymore, so that is a sign of stroke. Okay, if you get these three, the last one is time, so you need to go to the emergency immediately, so you need to be checked for stroke.
So my mom is actually having a blood thinning medicine, and the doctor said that it cannot be stopped. Is that right? So if stop eating the blood thinning medicine and you will have a blood clot or something, is that correct?
If you've been diagnosed with this, what we call an ischemic stroke, that means this is a stroke because there is not enough blood flow to the brain because there is a blockage. And this could be due to narrow vessels because of age, diabetes, cholesterol. She needs to go on blood thinners. And generally, patients who have been diagnosed with a stroke, more than 90% of these patients end up to be on long-term blood thinners. There are multiple different types of blood thinners, from warfarin to Plavix to aspirin, and some of them are more potent. Like Plavix can be a very strong blood thinner. Aspirin is not so strong blood thinner. Depending on the type of stroke and the comorbidities that the other factors involved in your mother's health, the doctor will prescribe a particular type of blood thinner. The important thing about blood thinners is that you need to be careful. You cannot have false cuts, because any fall cut can increase the risk of bleeding in other parts of your body, and the bleeding doesn't stop. So when you go on a blood thinner for a stroke, general rule of thumb, be careful.
When is the starting of all the treatment regime, from psychiatric, from physio, speech?
That's a great question, I think.
Can start right away.
Before discharge, wouldn't you say?
Yes, actually rehab starts from the day immediately, within 24 hours. If the patient is stable, okay, so we should start the rehab. Okay, rehab does not mean that you go to gym or anything, nothing like that. Right on the bed it starts. Okay, so and then the assessment continues. Okay, what is that disability that the patient has at that time? So we have to tackle each and every one the earliest possible. Okay.
Would you say it's for the caregivers to insist what kind of rehab is needed, because they may not be getting this multidisciplinary team by their bedside?
Yes, you should request. It's your right. Okay, it's a patient's right. It's a family member's right to request whatever therapy that is available. Okay, so if it is available, you have the right to explore.
Thank you. The catch is now she's in a private nursing home, spend almost 8,000 ringgit just for basic treatment. But we don't know how we should start this treatment of engaging this specialist, going to the nursing home or bringing her to a private medical hospital like SJMC. So money to us is not issue now.
Yeah, the first thing, we have to see her. So we have to assess, take good history, okay, and then examine her, okay, and then we have a treatment plan. Okay, if we are able to intervene, that definitely will counsel you what is need to be done. Okay, the place of rehab varies, whether it is in the nursing home or hospital, and all, depending on the patient's condition. We look at the benefits. Okay, we'll explain the benefits to you. Okay, whether how much benefit, what are the recovery that we can expect, and all that. It's based on assessments. Okay, so for your question like this, it's very difficult for us to like pinpoint your expected answers.
Thank you so much.
I want to touch on epilepsy drugs, and I think we need to get our dietitian. So some of you here might be on patients or relatives that you know post brain injury on anti-epileptics. That means drugs to prevent seizures. They've had seizures and now they need to go on medication. So I think there is some dietary precautions that you might need to know, and you need, maybe I get our dietitian to say a few words.
Yeah, and then after that we'll wrap up. I think in the next 5 to 10 minutes we'll wrap up after that. But please, Bin.
Okay, speaking about precautions for epileptic, yeah, have you ever heard of ketogenic diet?
Everyone's heard of keto
I
diet.
think that is actually specially designed for patients who are having epilepsy condition. Any precautions, I would say there is no special precautions as long as you are maintaining a healthy and balanced diet. I think that should do the job. But after, if there is any epileptic episodes, ketogenic diet, which is basically a very high fat diet, a very low carbs or even almost none, very minimal carbs, moderate protein diet, patients might benefit out of it, but it requires medical and also a dietitian to be in the picture, because it is actually not easy to practice a classical ketogenic kind of diet. So I think one of the most common issue would be reflux among the patients. So like what Dr. As mentioned earlier, sometimes the speed of us administering the feeding, it aggravates or it actually increases the risk of aspiration. So there are various ways. If it is in a home care setting, the placement of the syringe when we are giving bolus feeding, if you want it to be fast, if you elevate it higher, then the flow, because it flows by gravity, so it will goes very fast, to patients. So they might have a very unpleasant experience. So if you are able to make sure the position of the syringe should be at least jengkar tangan, yeah, or even if you want it to be slower, maybe you want to actually lower it down the position, it could help. Yeah, the feeding time, the feeding gap. There is actually one new newly launched products available in the market, but maybe it is not so widely known yet. It is called a gravity feeding bag. So meaning you do not need a pump, because if the bolus feeding is not tolerated, sometimes doctor might need patients to rent a pump to be put in the nursing home or even at home to make sure the rate of the feeding to be adjusted to be slow. Yeah, but not all the patients could afford it. Yeah, all right. Or even bolus tube feeding with the drugs, the risk of aspiration is still very high. So this gravity feeding bag, it doesn't require a pump. Pop the formula in, hang it 2 feet above the head of bed elevation. Of course, the feeding position is also important. We need to make sure they are propped up, yeah, or even after feeding, they need to stay at that position for at least 30 minutes. You might want to turn your patient to your right side to help with gastric emptying. And like what I said just now, with the gravity feeding bag, you will be able to set the rate. Yeah, so it will be relatively slower as compared to the manual bolus feeding that we're doing. But this is very new in the market. I have yet to experience that yet. So maybe we will get more updates on it later on.
I have a question here. Maybe Dr. Gromit or Dr. Muruga. What does research show regarding long-term issues for people after a traumatic brain injury, especially with regard to neurodegenerative diseases like dementia? Would you be at higher risk?
What happens with the head injury? It causes inflammation. So putting it simply, it opens the door for inflammation to set in. So, and this can be over the years. So therefore, it increases your risk of degenerative Alzheimer's, all this. So you're more predisposed, Parkinson's also. So you're more predisposed to these kind of diseases which are resultant of inflammation.
But is there anything you can do then to reduce that, to slow it down perhaps?
I don't think so. I'm sure there are some chemical agents that I
Classic example was Muhammad Ali. Boxer developed Parkinson's later in his end. And if you look at American football players who have a lot of concussions, also they are now seeing long-term sequelae from this. I think, to me, to summarize, is we have long-term problems with brain injury and we have short-term problems with brain injury, like quite highlighted here from the audience. Short-term injuries is getting to the right hospital, the right time, fast enough to get this addressed, and to get a panel of doctors addressing the problem, whether it's resolved or not resolved. Long-term issues from anxiety, it's sometimes for long-term problems, it's the small things that matter. Dietary issues, how fast you feed, what kind of food that we give these patients, and the physio. So I'm hoping that these kind of forums, which is good, which is a start, that people can come forward and ask questions, and hopefully we can have this on a regular basis, such that there is somewhere, there's an option, there's a panel.
Hi, doctor. This is for myself. I've experienced twice. I have a difficulty in breathing, and I think the oxygen doesn't reach my head, and I feel that at that point of time, I feel like I can collapse anytime. So, what are the doctor's advice? Should I come and do a follow-up checkup on my situation because I experienced this twice?
Please, low.
It could be a syncopal attack. It could be anxiety attack.
Do you want to explain what syncopal attack?
Syncopal attack is a sudden physiological phenomena which causes your BP. BP is one of that, like you drop and then you lose consciousness. But the way that you explained it to me, could it be anxiety?
I think the key is recurrent. The word is recurrent. If you think that you're getting these problems, you're feeling this very often, then it needs to be investigated. This is if it's once, but what we are seeing now is that I'm seeing a couple of patients which I've referred to the neurologist. They come to me as concussion, head injury. They've fallen in the bathroom, or they're walking and then they just fall. And when you sit down and ask them the questions, they didn't slip and fall. Doctor, I fainted and I fell. So fainting occurred first, then the fall. So it is not a neurosurgical problem, but a neurological problem. And we end up referring these patients to the neurologists. They are the smart ones. The neurologists are the real smart guys around us here. So none of them are here around today. The neurologists sit down and they assess this patient. So what we do is a workup. The neurologist does a full neurological examination, then refers to the cardiologist. We look for that the heart is beating regularly. Sometimes the heart doesn't beat regularly, and then they have this fainting attacks, and then they fall. Then you need to put a small pacer. So there's ways to go around doing this. In the past 3-4 years, I have referred about 5 or 6 cases in this nature.
We've discussed so much today. We've covered so much. So a takeaway would be great to one thing or two at the most for our audience to take away as they leave today, whether there are concerns about stroke, head injury, post-recovery and all of that. So one or two things from each of you, starting with Lynn.
Okay, so dietitian is always ready to help. Yeah, so if you think you need advices, because sometimes doctor might not have the time to address your your nutritional needs. So just let the doctor know, get referred, and come to us. Yeah.
To me, I think I take it very personally, and don't shy away from seeing a psychiatrist. All right, that doesn't mean that if you have anxiety or depression, you're labeled. Yeah, that's the right word. Yeah, don't shy away. And we are just like any other medical doctors treating clinical anxiety, depression. And trust me, these medications are so good. Their side effect profile is so excellent. And within 2 weeks, you'll see clinical improvement.
It's a life-changing event. It requires the whole family. We see patients who do not have family members, for example, the expatriate workers, the Bangladeshi workers, the Indonesian head injury patients, they don't survive. They don't survive. Even though the injury is not that bad. So therefore, it definitely requires a family input. Definitely the whole family has to come together. You cooperate, the outcome will be much better. And it's going to change the family dynamics. Somebody has to stop working. A lot of changes will happen. So if you do not impute this at the beginning, later you will get flustered. So at the beginning, the acute phase itself, you already acknowledge, Rab, I need to do this, I need to do this, I need to do this. So that by the time the doctor says, okay, you can go back home, only then you're running around looking for a bed, looking for a maid, looking for this, looking for a room to put your loved one in. So all this must from day one. Nobody will tell you this. You yourself have a lot of anxiety in the acute crisis, but hopefully with today's discussion, it will educate you. You can pass this message to somebody else also.
All the neurological condition, brain injury, okay, it's about rehab. Okay, there's already a loss of function. Okay, so definitely there'll be loss of function. Any neuron dies, that function is lost. So you need rehab. Rehab is not about only physiotherapies. Okay, there's a misconception there. Rehab is physiotherapy. Okay, rehab is about the whole body functions. There are many types of rehab. What we see is physiotherapy, occupational therapy, we have speech therapy, we have rehab physician, we have rehab nurses, we have recreational therapy, we have vocational therapy, and so on. Okay, so there's such a big field. So all the neurological patients must have rehab. Okay, so be it Parkinson's, be it dementia, be it just like a child with trauma, okay, with autism or whatever. So everybody needs rehab. Okay, so make sure rehab is not neglected if any of your loved ones are this thing. And here in Subang Jaya, we offer a complete range of rehab.
Thank you for coming, and I think it's great to have this first chance to meet the community with neurosurgical or neurological issues and problems. So, two things. First is we hear you. We hear you first is that we should go back today and tell management we need a protocol how to get patients who want to come into the hospital ASAP and get things done so that we can clear the anxiety of the community who are around us, okay, with stroke, head injury, and whatnot. Second thing is that I've also heard you that the community and the patients want a support group, and it's something that we should look forward to develop. This is a message we'll take back to the management. Tell them that we should look at working with some NGOs, some corporations, and to set up a support group, friends of the head injury or the friends of the brain injury, and have this kind of regular meetings and a panel of doctors or a panel that you can approach to discuss your common issues and common problems related to neurological conditions.
Thank you so much, Dr. Muruga, for that commitment. I think most importantly, commitment from the experts today, commitment hopefully from hospital, and commitment from all of you, because it takes all of us to do this. On behalf of SJMC, thank you so much for attending, for participating, for your questions. Thank you to our panelists again, Dr. Muruga, Dr. Mohana, Dr. Grumit, Dr. Raminda, and Ms. Huang Ke Lin.